everybody, it's Dr. Linda of the Vascular Birthmarks Foundation coming to you live, we think. It's saying live is starting. Okay, it says we're live. Oh, hold on a minute. Okay. I'm trying to find us on here. There we are. So that I can see questions. Let me come on here. Hi, everybody. It's Dr. Linda of the Vascular Birthmarks Foundation. Having a little issues, technology as usual. Hey, it's Dr. Linda. Oh, but we are on. Okay, this is great. Let me just turn the volume down. Because we're not hearing us through here. No. You know, but they'll be able to hear us. So I don't know why the microphone isn't working, but let me find us. Let me find the video of us on here so I can get our questions and people can tell us. Okay. I might have to keep this. It's saying we're live, but I have to. There we are. Okay. If you can see me and Dr. Waner,
wave your right hand.
Yeah, just text and say, can see questions? There we go. So we can see questions on here because we're not hearing it. And also let me know if you can hear us. Okay. So if you can see me and Dr. Waner, if you can, yeah, just text and praise your. So if you can hear us, and also let me know if you can you hear us? So if you can see me and Dr. Waner, if you can, yeah, just going. Yeah, I know, but I should be seeing people's comments. Can you hear us? Oh, watching. I can see and hear. Perfect. Great. Well, I know, but we won't be able to hear I don't know. Let me see. Okay. That's true. That's true. Okay. All right, everybody. Hi from the UK, Robin. Hi, Justina. We're on a little early, but we've had so much technical difficulty that we decided we're just going to run it for a whole hour, and that'll be fine. So, look, all of you who are on now, you have the advantage of being on early, and welcome, Dr. Waner, to our May is our month of awareness Facebook Live. And if you can't see, I'm wearing my Mother of Birthmark shirt, and Dr. Waner is wearing his VBF logo t-shirt because May is our month of awareness. And May, so we want you all to do your awareness events. See, we can see everybody over here. Alma, Jennifer, Robin, Sarah. Hi, everybody. We will take your questions as soon as you want to start submitting them. Also, let you know all of our booklets are in for port wine, Sturge Weber, and this is the hemangioma booklet. Frequently asked questions. Dr. Waner is a co-author, and we are working next on the lymphatic malformation booklet. Oh, Christine says, hi, Mom, and Dr. Waner. Hi. Say hi to Christine. Okay, let me see. Oops, I'm trying to see the questions. Now I went to something else. So let me see. Okay. I'm trying to see the questions on here. Oops. All right. There we go. 10 comments. There we are. Hi, Ortal. Hi, Tara Nesbeth. We are very happy to be here for May's Month of Awareness VBF Facebook Live with our first medical director, Dr. Milton Waner from the Vascular Birthmark Institute in New York. He usually goes without being introduced. All of you know him. He's been with me since practically when VBF started, so over 25 years. We've been doing this. VBF started in 94. I met you in 95.
Linda, it's over 45 years. Just kidding.
Wait a minute, it just said our internet was interrupted, so I hope we're still...
No, we're fine. You can see it.
Okay, Jennifer has a question. I hope you can hear us. Regarding maintenance treatments, how many consecutive treatments do you recommend in 1 year to maintain? She's talking about a port wine stain.
Yeah, you know, the maintenance treatments depends on the type of port wine stain, and it depends on how active the port wine stain is. So I can't dictate a number to you. All I can say is that you need to go by how the port wine stain is behaving. If it doesn't darken for a period of 2 years, then you don't need a maintenance treatment for 2 years. If it starts darkening after 6 months, then that's when you should have a maintenance treatment. So it's determined by the degree of darkening or the aggression of the port wine stain, and you should judge it by then. There's no fixed formula, there's no recipe for that.
No two port wine stains are alike.
Well, yeah.
Right? And you usually see when you do one how they respond, and each treatment you reassess, and you just hope for the best.
Correct.
Okay, so hi Ava Piles, she's saying hi to you.
Ava.
Hi Michelle Serio Goodwin, you did her son. Dr. Waner, hi guys, we're taking questions. Lots of people are on. Caitlin's on. Yahoo is on. And I know some of you. Oh, Dr. Waner will be in Israel this coming week.
Correct. Yeah, end of the week.
And next weekend for those of you. So any of you in Israel, Dr. Waner will be there, and he'll be seeing patients with Dr. Farkas
in Jerusalem at Shaare Tzedek Hospital. On Sunday, next week Sunday, so a week from today.
So they can be seen. There's no problem with you fitting them in.
Yeah.
That's awesome. So those of you who are logging on from Israel, you should know that. Okay, so the next question. Oh, we're waiting for questions. Dr. Waner and I will also be at the ISFA meeting together. Okay, Yahui says, thank you, Dr. Wynn, for this. Are there any treatments, management of port wine stains coming down the pipeline in the near future, i.e. angiogenesis, inhibitor creams? What is your take on sirolimus for management of port wine? I've read about cervicofacial advancement flap, and there's a lot in this.
Okay, so
take the treatment, and then we'll read the rest.
Yeah. So the bottom line is, there still is some experimentation with something called photodynamic therapy. Now, I have experience with photodynamic therapy for cancer treatment, and when I first became a specialist, I began using this for cancer treatment. And I published 1 or 2 papers, but not for port wine stains. There is work in Shanghai going on using photodynamic therapy for port wine stains, and they believe, or they claim, that one treatment with PDT is the equivalent of 3 or 4 regular treatments. But we've yet to see the results, and we've yet to confirm the results. So that's one possibility, is photodynamic therapy. But all of these treatments, all of these treatments concentrate on the effect and not the cause of the port wine stain. In other words, the effect is dilated blood vessels and a red color. The cause is a genetic defect which prevents the blood vessels from vasoconstricting. And that's where we need to be treating port wine stains in order to be able to cure them. There's nothing at the moment in the pipeline that's looking directly at that, at least not anything that I'm aware of. People have used rapamycin without much effect. I know Stuart in Irvine, UC Irvine, has looked at rapamycin and wasn't that impressed. Sirolimus is not in the pathway for port wine stain management, so I would not use sirolimus. Sirolimus is an immune suppressant, and I would certainly not like to be on an immune suppressant for a long period of time, especially if there is no known benefit. So none of the drugs that we know of have any effect. However, there are pathways towards creating blood vessels for a port wine stain. There are biochemical pathways. And there are lots of drugs which are active along various parts of this pathway. So I've no doubt that at some point we'll come up with some VEGF or anti-angiogenesis factor which is active in the port-wine-stain pathway. At this point we don't have anything, but I'm sure that something will come up at some stage. But once again, we need to be directed at the cause of the port-wine-stain, and perhaps drug therapy can stop this.
Yeah, and my apologies, I just actually was reading an article on the train, that's what I was looking for right now, about a new study going on where they call it LADD. So it's this laser application of like a topical Rapamune. So they're using the laser to deliver the Rapamune and they're lasering it. And this study just came out of China and they're saying they're getting like 30%. So I just read it this morning.
Yeah. So so what they're actually doing is, when you apply something topically, your skin is protective. The skin stops a lot of things from being absorbed, and the keratin layer, which is the outer layer of your skin, is a barrier towards the absorption of various substances. Otherwise, anything that you put on your face or on your body would be absorbed. And so what they are doing is they're actually making holes in the keratin layer in order for whatever drug it is to be absorbed. We looked at this, and in fact, a long time ago we did a lot of research on laser-assisted drug delivery. In fact, I think we even have a patent on this. And it works, because if you get rid of the keratin layer temporarily or for a short period of time and put a patch of something on it, it'll get absorbed.
So that may be something.
Yeah,
being resurrected from your patent.
Possibly.
Okay, so Azza said, my son is 9 years old from Mongolia. He's been diagnosed with hemangioma on the left cheek that has been replaced by a blood vessel or enlarged by an oral trial. Doctors in Mongolia said it is incurable. Will you be able to help us? How can we contact you?
Okay, so you can contact me through my email, and Linda can forward that to me.
We're going to be posting his email in the string, but for Azza, it's mwmd01@gmail.com. That's MW for Milton Waner, MD01@gmail.com, and we'll be posting that in here.
Yeah, so what you should do is send me a photograph of your child, and with and as much detail as possible, so that I can get a sense of what's going on, and then I'll be able to give you an opinion.
Thank you. And Elahi's on, and she's saying hi to both of us.
Right.
Oh, I just put the wrong email. It's Milton Waner, MWD01 at Gmail. Okay. Fat fingers today. Oh, see, I can't even type that right. I'm not having a good day.
Waner.com. Yeah.
There we go. That's correct.
Yeah.
Okay, so Jennifer wants to know, do you know when the photodynamic therapy might be available in the U.S.?
We've been waiting for many years for this. I don't know where they are in the approvals process, so I can't definitively answer this question, but we'll have to wait and see. So I can find out, but I really don't know at this stage. I'm sure that they're looking at an approval process. So,
and sure. This paper that came out talks about a lot of new things coming down the pike for port wine stains. So I'm very optimistic about new delivery methods and lasers that can go deeper, bigger spot sizes that we're seeing. Yeah. So I think everybody should remain optimistic.
What is the situation with the YAG laser and port wine stains, Linda? You know a lot about that.
Well, I mean, using it by itself is pretty painful if you don't have any anesthesia.
No, but the effect on scarring and so on.
Right. So
it's been withdrawn, right?
The Prima, you mean? The Prima.
Yeah.
Well, it's not being remanufactured.
Okay.
It's not being remanufactured because it had two laser components, the YAG and the PDL, and they weren't synergistically, the synergy between the two of them was collapsing. So now everybody's kind of, some people are still using it effectively and they're not having problems, but other people are. But the good gold standard is still the pulse dye. Yep.
Yeah.
So Lydia Nikolova says, "Hi, Dr. Waner. You made a laser surgery to my daughter March in Berlin. Returned back to Bulgaria. She made an angiography, and the result is that there are big anomalies in the aorta, perhaps linked to face syndrome, which it sounds like. Are you able and willing to look at the scanned results if she sends them to you? Because she said no one there knows how to interpret them."
The results of
From the imaging.
of
imaging
of the aorta.
Yeah.
I'm not a cardiac surgeon. I can get somebody to look at them, but I'm not a cardiac surgeon, and I'm not a vascular surgeon. So
Maybe we can get Dr. Rosen to look at those?
yeah, I can have Dr. Rosen look at them. So if you send me some imaging, I'll have Dr. Rosen look at them.
And Dr. Waner's email is there if you have to do some kind of a drop for, medical records.
Yeah.
Yeah, that's the same one that we just read. That's the
Okay.
one that we just read. So I know there's a lot. Oh, see now a lot of people will start coming on a lot more because we posted it to start at 12, but we went live at 11:45. We've already been on for 16 minutes. So I know there's like 27 people are on now, but for those of you, we've been on for 15 minutes just because of technology issues. We just went live because we were having a hard time.
Linda's challenged with technology.
Yeah, I'm challenged every time I'm in this building. I'm challenged, all right. And then once again, I'm wearing my Mother of Birthmarks shirt in honor of May as our month of awareness. Dr. Waner is wearing his VBF logo shirt.
How come I don't have a father?
You could be the father with the mother sitting right next to you. I don't know how that looks, but
that'd be very good.
yeah, maybe I don't know. Maybe somebody might argue for that spot. Hi, Bethany. Hi, James and Stephanie. We're live and taking your questions. We've been on already for 15 minutes. We got on early because we were having a lot of technical problems, so we just said let's just start. And thankfully, there were a lot of people who were on and asking us questions.
There is a ISFA coming up, and ISFA is the society. Just one second, Benjamin. I'll call you back. I'm on a live session. Okay. There is a conference coming up, and one of the issues at the conference is what is the long-term effect of propranolol on children with port wine stains. So they're looking specifically at cognitive development and so on and so forth. And there is some mini seminar that's going on, and I'd be interested to find out what the results are, because we do use propranolol, and some of these children are on propranolol for long periods of time. And we know that propranolol does cross the blood-brain barrier. In other words, it is active in the central nervous system. And so for that reason, there has been some concern about what effects this may have. Nothing has been found to date, but I am very interested to see the presentation at ISFA to see whether or not they've been able to find anything.
And I will be looking forward to that presentation as well. I will be there. And won't you be looking forward to my presentation?
Yeah, absolutely. Yeah.
With enthusiasm? Okay, Melinda has a question for you. My son is experiencing what seems to be hypopigmentation around his port wine on his cheek. He's had 14 treatments, mostly with the Prima. Is the YAG and the Prima causing this? Should we switch to Perfecta? Because he's getting hypopigmentation.
Yeah, It could be the pulse dye laser, and it could be the YAG laser. The YAG laser typically doesn't target melanin or pigment-forming cells. So the neodymium YAG laser itself, unless there has been scarring or ulceration and scarring, the YAG laser won't cause this. We do see with many treatments with a pulse dye laser, in some patients, hypopigmentation, in other words, loss of pigment. And if this is the case, perhaps you should hold off for a while and let the pigmentation recover, if it is going to recover. I'd be interested to know, was there ulceration after any of the treatments? Was there any scarring or any other issues? But we do know that many treatments with a pulse dye laser can, in some patients, cause hypopigmentation or loss of pigment.
Also, Scott is on. He's responding as VBF. He's our new COO. So shout out to Scott. And I just want to let Scott, I want you to know we started at quarter of. Due to technical reasons, we stayed logged on because our tests weren't working. So we've been on since quarter of. Just want you to know. Hi, Mentor from Albania. And so hemangioma, and she's saying, why did my hemangioma appear when I got old? PDL laser is not working for me. So I think she needs to send you some pictures.
Yeah, you don't have a hemangioma.
Likely not a port wine either, especially because she's an adult.
Yeah, so you should send us some photos and some history, because I think you need an accurate diagnosis. You need to know exactly what you have before treatment can be prescribed.
Hi, Mentor. He's on. He wants to know how many laser treatments a person should have a year.
Once again, there is no recipe. It depends on the port wine stain, and it depends on whether you're in the initial treatment phase or you're in the maintenance phase. If you're in the initial treatment phase, some people will prescribe or will administer 2 or 3 treatments a year. Others will administer 2 treatments. It depends on whether you're in the early stages or the middle stages. I prefer to administer around 2 treatments a year in the middle or late stages of a port wine stain treatment. And then when we go into the maintenance phase, the number of treatments will be dictated by the behavior of the port wine stain. So there is no fixed number that I can give you.
And remember, no 2 laser doctors agree either. So, some treat once a year, some treat once a month.
Yeah,
Depends on where you're at, like you said.
Yeah, I feel that there are not too many who treat once a month, and that's perhaps a lot.
What about in babies?
In babies, in the initial phases, maybe once every 6 weeks, but you haven't even fully recovered from a port wine stain treatment in 2 or 3 weeks. So I'm very uncomfortable with repeated treatments over a short period of time. But once again, it's a controversial issue. There are other opinions.
So we are live from New York City, Dr. Waner with Dr. Linda of the VBF. Oh, Tara Nesbitt, she goes once a month. I believe she sees Stuart Nelson, Dr. Nelson.
Yes, so Dr. Nelson's very experienced. And he knows what he's doing. So
I think that's the key, don't you?
Yeah.
You have to go to an expert.
Yeah.
And if it's the first time for you, ask to see pictures of patients that they've treated. You've always provided those to your patients. Let them see the work that you've done. So I got the questions here. She's taking a break because she had surgery. May is the VBF month. So Stephanie's on, and she says, I was wondering if the port wine stain come from Kaposi form of lymphangiomatosis. I believe my daughter has a port wine stain in the scalp and on her leg under blebs, which has been lasered in the past due to profuse bleeding. Well, that she's got that KLA, that's that Kaposi form of lymphangiomatosis, which has a lot of comorbidities with it, a lot of wonky involvement. I'd like to see some pictures, Stephanie, if you could email me of that, because
so
that's a very unusual diagnosis unless it comes from a real expert, like Dr.
Sure.
Adams or Dr. Treat or yourself, somebody that's actually knows how to diagnose it.
I mean, the issue is that the bleeding can be controlled. If it is lymphatic in origin, then it will respond to intralesional bleomycin injections, and we've had very good results with that. There is a clinical trial going on at the moment looking at superficial lymphatic malformation with a certain topical or topically applied drug, and we're hopeful that I'm participating in that, and we're hopeful that that will have a good effect.
Right, and VBF is also working with Dr. Waner and the biotech company on that, so we're very hopeful. But also, again, because she says a port wine stain with lymphangiomatosis is kind of curious, so it seems like something's not right.
We need to review the diagnosis because it doesn't sound right. I mean, it may be Kaposi form. I'm not sure.
You have to see pictures.
To see it,
Oh, and Tara corrected me. She's actually seeing Dr. Duarte once a month.
Yeah, so Dr. Duarte is experienced.
Yep. So Jamie wants to know, have you done any sclerotherapy? Are results helpful with laser treatment? So Jamie has a port wine stain and I believe some hypertrophy.
Yeah. So the issue with port wine stains is it's very interesting. The port wine stain is segmental in origin. When the body develops embryologically, it develops in segments. And where there's a port wine stain, one partial or whole segment is involved. It's an embryological segment. And one of the things that we see is growth abnormalities within that segment. And these growth abnormalities continue throughout the life of the patient. However, during the rapidly growing phases of the patient, i.e. Around puberty, early age, and so on, one tends to see overgrowth within these segments. And that overgrowth affects all of the layers. It affects bone, muscle, subcutaneous tissue, as well as skin. Sclerotherapy will have no effect whatsoever on that overgrowth because it's not a vascular malformation per se. It's extra tissue, it's overgrowth. So sclerotherapy is the wrong treatment for overgrowth. Overgrowth can be corrected surgically. Unfortunately, the surgery may have to be repeated, but we get very good results in correcting this overgrowth. But once again, sclerotherapy, I believe, is not indicated for port wine stains or for the overgrowth.
Okay, and Stephanie Ainsworth said her daughter, the one that was diagnosed with the KLA, is on sirolimus. I'd just be curious to know who diagnosed her with that. Hello from Bulgaria. Are you still traveling to Eberswald?
Yes, yeah. So I'll be in, I think we've just fixed a date in September, so I'll be there again in September. I could go sooner, I'd have to communicate with Dr. Meyer, but definitely I'll be there in September. BG,
again, send your pictures to Dr. Waner. That's what he was requesting before so that he can give an opinion on what your child has. Okay, so we're pretty much caught up for now. So as Dr. Waner was saying, he will be in Israel next week for anyone who wants to see him in clinic. And when will you be offering laser? Will that be on your next trip or this trip?
No, we still have to negotiate that, but
okay.
That's a possibility. One of the interesting things there are two papers that we're about to publish. and one of them is very, very disturbing. We looked at around 400-500 children with eyelid hemangiomas, and what we found was very, very alarming. We found that 10% of these children were already blind in that eye by the time they were first seen by us. So in other words, current treatment is missing something. With 1 in 10 children with an upper eyelid hemangioma already blind in that eye by the time they first referred to a specialist center, I think is a major problem. And so that paper is about to be published. And then the other paper that we're writing at the moment is a paper where we found that there are several patterns of overgrowth within port wine stains. There are cobblestones, there is regular overgrowth of structures, and then there is something we call hamartomatous overgrowth, which is massive, massive overgrowth of the tissues. But each of these is treatable. We can make these look pretty normal, but the only way to do this is through surgery.
Okay, so Ram Malka is going to be seeing you next week, saying safe travels, so
yeah.
That's excellent. And a lot of more people have signed on. Dr. Waner is here live with us to take your questions. So while we have, another, 40 minutes.
One of the things we've been doing is we've been reviewing the pathways within the body which result in the various malformations. And there are 2 distinct pathways. There is the RASA pathway and the PIK3CA pathway. So these are 2 distinct pathways. However, there is crossover between these. And we found that the various drugs which are used to block these pathways are more effective if they're used in combination. So in other words, if you use just one drug, it's not as effective as if you would block these pathways at various points. And that says to me that we don't fully understand all of these pathways, and there are certainly some things that we're missing. And a lot of this research is going on. It's very interesting, and at some point, if I can predict, in 10 or 15 or 20 years' time, we may not even be using lasers. I don't know. Maybe that's just speculative.
Well, so why Rini, the one from the Philippines, said, this is troubling to me that her biopsy says arteriovenous hemangioma, and she's had 5 or 6 laser treatments. I'm a little concerned about lasering it if it is even
we need to review the diagnosis.
And the pictures.
According to currently used terminology, arteriovenous hemangioma does not exist. It's not a recognized diagnosis. So are we referring to an arteriovenous malformation, or is this some kind of hemangioma, whether it's congenital or infantile? So the classification and diagnosis is something we should review.
So Ortal has a question for you. She's inquiring about lymphatic malformation surgeries, like about how many of those do you do a year?
Oh, a lot. Really a lot. I treat only vascular malformations, and so I see lots and lots of lymphatic malformations. So, how many a year? I don't know. I can't. I can go back and look at it, but it's a lot.
Probably one. I would say, how many surgeons in the world do as many cases as you? Very few, right?
Yeah, correct. Yeah.
So that's the key: is how many are there that do it properly? So here's a question. Sasan says Ariel Wogman in Israel was diagnosed with malformation in neck area. The question is whether the treatment removes the cyst and lymph system is fixed as well.
Yeah, so what we do is when we do surgery, first of all, in most cases there is some sort of combination of therapy. It's not all surgery. It's usually surgery with a bit of sclerotherapy, depending on the type of malformation. So what we do is we remove the abnormal tissue. Now, surrounding this abnormal tissue is, just hold on a minute.
Yeah, but he knows you're on this.
I'm on a live thing. I can't talk. Is this urgent? You'll wait for when I get there.
Can you turn it off?
That's rubbish. All right. So, what was I talking about? So when we remove lymphatic malformation, we remove the most abnormal tissue. But surrounding this is tissue which is perhaps less normal, but not fully abnormal. So in other words, there may be some marginal tissue around there, which then activates because of the trauma. So to answer your question, when we remove these massive cysts, they're gone. You know, they won't come back. There may be some activation of the surrounding tissue, but we can treat that with steroids temporarily and with sclerotherapy. So when we remove lymphatic malformation, the lymphatic malformation that we've removed does not come back. There may be activation of surrounding tissues, but we know how to deal with that. So the treatment of lymphatic malformations should involve drugs. Sirolimus is a known treatment, surgery, and sclerotherapy. And we have to look at a combination of these treatments, and we decide which treatment based on the patient, not based on the preference of the treating physician. So in other words, if you have a hammer, everything looks like a nail. So if I'm a surgeon, I'm going to want to operate on everything. That's wrong. We should choose the treatment which best suits the patient. In some instances, it's surgery. In some instances, it's sclerotherapy. And in some, it's medical therapy.
Or a combination.
Or a combination, correct.
So hello to Barbara Humphrey. She's our new VBF partner with Remington Laser in Alberta, Canada. Excited to be announcing they will be doing a free laser day in Canada for Canadian citizens. June 11th, we'll be posting about that, so we're very excited about that. You have quite a few patients that are patients of yours, Irina Kondralik and Zolkofil Yusuf. Some patients are just saying hi. Oh, Stephanie Ainsworth says her daughter has the PIK3CA gene. So that's the one with the KLA. Alexis Sorensen, my 5-year-old, had sclerotherapy on his KTS leg in November. He had a significant blood clot that hasn't resolved since, and this has reduced the quality of his life. Is there any other treatments for his venous malformation outside of sclero?
Yeah, depending on where the blood clot is and what it's doing, you know, once again, surgery may be indicated. So, you know, I'd have to look at it and look carefully at exactly what you're talking about. But choose what's correct for the patient. If you're seeing an interventional radiologist, that doctor may want to embolize or sclerose everything. Overlooked, and surgery may be indicated at some stages. So it's very, very important to have a multidisciplinary approach to these problems. And the more we see, the more we realize that a multidisciplinary approach is very important.
And that's why you want either a multidisciplinary expert like yourself who's comprehensive in all areas, or a good team, you know, but
Sure.
you need the expertise is the key. So we have Maria who's on, Litz is on, Elizabeth is on, Boyan is on. We're taking questions right now. So she has a second question. The swelling in the tongue can be treated as well.
Yes, correct. There are different ways to treat it. Swelling within the tongue can be due to swelling under the tongue or in the tongue, or a combination of both. When the swelling is under the tongue, that has to be addressed because the tongue sits on a shelf, that shelf being the floor of the mouth. If the shelf expands, the tongue sticks out. It's called glossoptosis. If we look at that and decide that the tongue's too large and remove a portion of that tongue, we're doing the wrong thing because what's causing the tongue to stick out is the floor of mouth. And that's what needs to be addressed. We can address that surgically. We can address that with bleomycin or with sclerotherapy. So we have to look specifically at what the problem is.
Okay, thank you for that. Elizabeth wants to know, does laser treatment for port wines have radiation? I'm concerned.
No, not at all. It's visible light. Radiation is in a different spectrum. So we have something called the electromagnetic spectrum. The electromagnetic spectrum, light is a wave, radiation is a wave, and so on and so forth. So X-rays are waves. Now, the spectrum of these waves is such that you have electromagnetic waves and you have light waves. And in order for something to cause problems, it has to interact with DNA. And that's what radiation or electromagnetic radiation does. Light in and of itself does not. In other words, light from a laser, whether it be yellow light or red light, does not. Now, there are certain lasers that emit low wavelength radiation, and that could potentially do that.
But not the PDLs.
No, but none of those are used
for
medically to treat birthmarks.
Stephanie, the one whose daughter has KLA, just one day add something that her daughter had to have surgery twice in a space of 2 weeks because the lump they removed from her neck filled back up with fluid, and this is the one diagnosed with the Kaposi form of lymphangiomatosis.
Yeah.
So again, just send whatever you have to Dr. Waner. You can copy me on it if you want, because I'd be very interested in seeing who is doing the diagnosis and what it's
so
based on.
If something, this can happen. If something fills up with fluid, then perhaps a drain should have been left in the wound, which could potentially have prevented this.
The second surgery?
Yeah, or perhaps the drain came out too soon. A lot of things can explain this, and a lot of things are not preventable.
Okay, thank you for that. So we are taking questions. We have been on for 42 minutes. We'll go over a little bit because we promised 12 to 1, but we'll see how many people are on. So any questions that you have, I think we're pretty caught up. Again, Dr. Waner will be in Israel this up-and-coming weekend. Okay, that's from Jamie. Oh, she'll email you. This is new to me. I would appreciate your professional advice. So I guess she's having that surgery because she's one with hypertrophy, but she wants you to take a picture and give her your opinion
I think
because she's concerned.
And also, tell me where you are.
Yeah, who's doing it? Who's doing the surgery, Jamie? Let us know. And so just let us know. I don't know. It might be Dr. Richter in Little Rock. I'm not sure, but let us know who it is and send Dr. Waner your picture, and he'll at least give you an opinion as to whether you're doing, what the treatment option is, right?
Yeah.
So. Okay, we have more people watching, and again, Dr. Waner will be in Israel next weekend. Third question, is there an incision opening in the neck that created at birth that infects the child? I don't know what that question is. I don't understand it. I don't know. I don't know what that is. Can't understand your question.
So there is I think there is tremendous development in new drugs to treat vascular malformations. And, this is an exciting field. At the moment, we do interventional radiology, we embolize, sclerose, and we excise. But it seems that there are certain drugs which can be very active in this field. And it seems that if you use several drugs at the same time, in other words, you affect these pathways that I've told you about at different levels, you can get a much better result. And the same thing happens with cancer. If we use one agent, we get a good result, but if we use multiple agents, we get a better result. And so, the same thing is true in several fields in medicine. But this is very exciting because at some stage we're going to be doing more and more of these drug therapies.
Jennifer has a good question. Is there a way to differentiate a port wine from a salmon patch? Because usually the salmon patches go away.
So salmon patches are midline malformations. The front one is the angel kiss, or it's commonly known as the angel kiss, and the back one is the stalk bite. Now, these are very common. About 50-60% of children have them, and the front lesion is usually V-shaped, and it has its root right at the root of the nose, and it's a V-shaped lesion going up on the forehead. There is also often a component around the edge of the nostril and in the middle of the philtrum of the lip. These are midline malformations. We know that some of them disappear. Whether they actually completely disappear or not, I'm not 100% certain because no one's really studied that. People have studied the back lesion, which is the so-called stalk bite, and they claim in the study that 50-60% of those disappear. I'm not sure if they disappear. I believe that they lighten with time, and they become less consequential. But these lesions are not port wine stains. They have various names.
Salmon patch,
nevus
midline capillary malformation,
nevus simplex, etc.
But the thing is,
the treatments will get rid of them. And I think it's very disconcerting to have a red V-shaped lesion in the middle of your forehead. So many people seek treatment for this.
Thank you for that. And we are taking questions. We're all pretty much caught up. And Jamie Henley, who's doing your surgery? Just, you can text me or you can post it here. I'm just curious where you're having it done. I think I know where you live, but I'm not sure.
One of the issues is, and we find this fairly commonly, is what the patient understands about the procedure that is about to be performed is sometimes a little different from what's actually going to happen. So every now and again a patient will come and see me and say, oh, the doctor said this and this and this, and is going to do this and this procedure, which sounds wrong. But when I call the doctor and discuss this with them, I get a much more medical opinion, and it sounds perfectly reasonable. So sometimes the way we understand what our doctors have said is not completely or entirely correct. And so we need to be very careful, and we need to try and understand as much as possible. And as doctors, we need to explain as much as possible so that the patients will know exactly what's going on.
Also, just all of you who are tuning in, Dr. Waner will be at the VBF Super Clinic and Conference in Irvine, the weekend of October 7th and 8th. You can register at birthmark.org/conference, and there are free clinic consults, free laser, free ultrasound, free dental. So any of you who are trying to get to see Dr. Waner, that's just one option. He also, when do you have your clinics here? Every Thursday?
Tuesday.
Every Tuesday.
Yeah.
Okay.
But I am able to see patients on other days, all other days except Wednesdays.
And also for the patients that have the lymphatic malformations with a superficial component for that clinical trial,
so
you're willing to screen those, right? Those
Sure.
patients, so they can come here and get a free screening.
Correct.
To see if they would be amenable to the therapy.
Correct.
So
there is a topical agent for something called lymphangioma circumscriptum, which is lymphatic malformation on the surface of the skin, wherever it is. And we're involved in this clinical trial to see whether or not this topical agent is effective. We do have other treatments for this, so we can prevent a lot of these.
So Jamie's seeing Dr. Reddy, who is a maxillofacial surgeon, and because she's the one with the overgrowth, but he's got to extract some teeth, so he was going to do some sclerotherapy while he was doing the extractions. I mean, for her, she said he was going to do some sclerotherapy on her face. It's bumping out, thickening. He says that it will help with future laser.
Okay.
I don't know. Keep me posted because I'm interested to hear how that goes. Anne Marie said my 2-year-old son has a venous malformation on the top of his foot that was removed but came back 6 months later. He's being treated at UCSF. Are there other options to remove it?
Yeah, so there's sclerotherapy, when a lesion comes back so soon, it means that the lesion was not entirely removed. Now it is possible that the surgeon did not intend to remove the entire lesion because some of the lesion may have gone into important structures. So there are other ways of treating this. There is sclerotherapy, there is sirolimus, etc., etc. So there's medical therapy, sclerotherapy, and further surgery, and sometimes a combination of both of these.
Hi, Jeff Martini. I see Jeff is on. We just did a couple of shout-outs for patients to come and be screened by Dr. Waner who have the superficial lymphangioma circumscriptum or have been diagnosed with a lymphatic malformation and they have like a bumpy superficial texture. They may not even know it's lymphangioma circumscriptum. They may have been told it's lymphatic malformation.
Sure. Yeah.
So he's doing screening. So you can contact him. His email's there. Or you can contact me and I will put you in touch with, it's actually Ronnie.vbi.
Correct.
At, Ronnie, we'll just get you the email.
Yeah.
Okay, so that's the same question from the one you just answered about. And the other thing is you got to find out what the diagnosis is. Is it intramuscular venous malformation? Is it even really a venous malformation? What is it?
Yeah, so I think the diagnosis, the proper diagnosis is very important, and that will determine the type of treatment.
Mm-hmm, absolutely. This is Dr. Linda, the VBF, and I'm doing VBF Facebook Live during this very important May as our month of awareness with our founding medical director, Dr. Milton Waner, world-renowned expert in all things vascular birthmarks, anomalies, and related syndromes. That's a new term we've coined, VBARS, vascular birthmarks, anomalies, and related syndromes. And we're hoping everybody uses it because it is a big umbrella, and there's so many different, there are birthmarks, and there are anomalies, and then there are the syndromes. So we are on still live for another 20 minutes. So we can keep taking your questions. It's been pretty active so far. We've actually been on for 53 minutes. So I guess we have maybe 10 minutes left. Sorry about that.
Do I get paid overtime?
No overtime for you today. This is your month of awareness.
I am very aware.
You are aware, yes. I'm aware of it too. And don't forget, everybody, May 15th is our International Day of Awareness. You got to put on your birthmark a red heart. I should have done that today. I should have put red lipstick on both of us. I don't know how you would not. Yes, you could see. Yeah, that wasn't going to happen, was it? I didn't think it would.
Sure.
Anne Marie wants to know: does VIJOICE work for that? His venous malformation had the PIK3CA gene mutation. They said sclerotherapy would not work since it was so large and would just come back. I don't know what VIJOICE is.
Yeah, it says maybe one of the drugs.
I don't know.
What is that? Is that a drug or what is that?
She just said it's a PIK3CA gene, so you know that's the pathway.
Yeah.
It's typically sirolimus, right?
Well, there are a number of VBF and so on and so
Right,
forth.
inhibitors.
There are a number of pathways which, or a number of drugs active at different levels along these pathways to prevent this from happening. So usually just one drug on its own is not going to be as effective as multiple drugs. So that's what we're learning, and that's what's very important.
Okay, so we're still taking your questions. We have quite a few of you on. We've been on for 55 minutes, but we did start early because of some technical difficulties, but we will be on for another maybe 10 minutes. So then we have to call it, but it'll be a full hour. And by the way, you can go back and review all of the lives that I've done with Dr. Waner from 2017 till now on our YouTube channel. If you go to birthmark.org, up at the top you'll see our YouTube link, and you can see all the videos that have been there since 2017 with Dr. Waner. So Clark Aletta that UCSF recommended that we wait until he's 4 or 5 to treat it. We have been happy with this approach until now. It seems like for psychosocial reasons, we would like to look into the possibility of surgical removal.
Yeah.
We're wondering about the benefits of waiting longer versus removal now. Also, we will be in New York this summer. We live in Northern California. We're wondering if your clinic is a possible place to have it done.
Oh, absolutely. You know, very often patients are told to wait. Now, the only reason to wait would be if waiting will change the way in which it's going to be treated. So, for instance, if it's a hemangioma and the doctor thinks that a lot of it will involute, and by waiting less of a surgery will be necessary, well then that may be beneficial. But once again, you have to consider the other factors. So, for instance, if the lesion's on the middle of the face or very visible, then there is a psychosocial impact. There is a psychological problem associated with this. The child has got something which is very visible and very disfiguring. Is waiting appropriate in these instances? I believe not. I believe that if you can remove the lesion, then just go ahead and remove it. Why wait? Does waiting offer any advantage? No, it doesn't. If you know how to remove vascular anomalies, and then just go ahead and do it. So, you know, I don't want to second guess why your doctor in San Francisco said you should wait. However, if you do want a second opinion, I'm happy to offer one, and we do remove these all the time. So if you are around, we'd be happy to help.
Yeah, she could send you the pictures now, and
Sure.
then let you know their window of time when they're in the city, and then you could put her on
Sure.
the schedule.
So you have my email address.
Yep, it's right in.
Yeah,
in
so
the
go
thing.
ahead
Yeah.
and send me some photos, and send me a little bit of the history so I can get a sense of...
And the dates when they'll be in the city.
Correct.
Yeah, and the dates when they'll be available in the area.
Correct.
Again, this woman is trying to clarify. She's having problems with the translation. She's saying, what is the recommended treatment to prevent speech and eating issues because of the increation in the neck? I think what she's saying is there's a
Lymphatic.
lesion, there's like a lymphatic lesion in the neck. I'm not sure.
So if there's a lesion in the neck, it may come through the floor of the mouth. It may deviate the tongue to one side, so the child may have some speech difficulties. I think the most important thing is to deal with the malformation, to get rid of it, and then to deal with any residual speech abnormalities associated with it. These are all treatable. They should be. Is this patient from Israel?
I don't know where they're
Yeah.
from, that one. She's just, she has your email to send you
Sure.
the information, but if she is in Israel, she should let you know, because then you can see the patient.
Correct.
Marcia Carr is saying her granddaughter was diagnosed with a hemangioma in the nasolabial area. We were able to get the ped derm doc within 3 days and started her on propranolol 3 times a day. It seems to have stopped growing, though there is still a hint of bluish skin next to her nose. Will that eventually go away, or will it stay?
So how old is the child? That's important.
She said, you just said, she didn't say.
So if there is a bluish stain, that means hemangioma underneath the surface of the skin. If the hemangioma is on top of the skin, it's red. If it's bluish, it means it's underneath the skin. Now, the hemangioma will continue to resolve up till about 3.5 to 4.5 years old. After that, there's almost no resolution or involution, or very little further involution. So we typically say that what you have by that stage is pretty much what you're going to get. If propranolol was started very early, propranolol doesn't always shrink the hemangioma to nothing. In some instances, it will stop the hemangioma from growing, and in some instances, it will also shrink it. In those cases where it just stops it from growing, we sometimes have to deal with the original hemangioma. So we have to remove it or do something with it. So, once again, there are opinions, there are different opinions, and I'd have to see the lesion and get some...
She's only 12 weeks old.
Oh, okay.
So,
I wouldn't remove it at this stage.
I'd just let it do its own thing, right?
Of course, yeah. Will the blueness go away? You have a 50-50 chance. If it doesn't, it can be treated.
So we're going to be wrapping up in a couple minutes because we're already at 1 hour. We don't want to, we know that we said it was 12 to 1, but we actually had to start early because of technical reasons. But again, Dr. Waner's email is repeated throughout. He will be in Israel next weekend. He will be in Germany in June.
And probably in September.
In September. And then in October, you'll be at the VBF Super Clinic in California. All of those are options, and obviously New York City is always the option, and your clinic is every Tuesday.
Right.
So if you want a consultation, and she just said thank you for taking a question. If you want a consultation, you can get in touch with him. I think we'll wrap it up, Dr. Waner. So thank you for your time, and remember, everybody, May is the Vascular Birthmarks Month of Awareness, and May 15th is our International Day of Awareness. So remember to put on your birthmarks, stay safe, and stay healthy. You want to say goodbye?
Bye.
Okay, bye.